like in mental illness and lack of taking care and precautions of our physical structure. So I want to charge us as salt this afternoon with the words of Jesus. You are the salt of the earth. And as we seek to preserve ourselves by being adherent to knowledge, and also by helping one another as we travel along. I pray that the Lord's blessings will be upon us, and we will not just be receivers of the word, but we will be doers. And may, as we look at prostate cancer and men's health on a wider circumference, that this discussion will not make us afraid, but will impact our state of mind, that the Lord says. And I was looking at some things that the Lord cares about our now, and our now will determine our then. So may the Lord help us, and may the Lord be with that family in Brandon Hill, and may the church learn from that experience that we can't just be near, but we must be dear, so that we can influence each other for quality life on earth and for certain life in the life to come. Let us pray. Thank you, Lord, for all those who are online, our special guest, from whom we will extrapolate knowledge, but give us more than knowledge, give us determination, and give us a sense of mission that we do not only embrace for ourselves what we learned, and it's not just to have a program from a department, but Lord, it's a movement of mission, because the mission relates to here and the mission relates to there. Guide our deliberation, make it on point, and Lord, we just pray that sooner we'll be done with the troubles of this world. And while we look forward to going home to reign with God, we live our best here and now. Thank you, and take over now, and let your will be done on this platform. This is our prayer in Jesus' name. Amen.
Thank you so much, my pastor. Certainly, we appreciate the words of encouragement to all of us as men and women who are on Sept in this very important forum. But to share one's experience, I've asked Brother Ron God. He is a survivor, a cancer survivor, and he will just share a bit of what he went through, how he has been one of those persons who helped men to understand that, fearful though it be, you can live. So, Brother Ron, over to you.
Okay, good evening, everyone. Good evening. Thank you for having me, Pastor Johnson. All right, so my prostate cancer journey begins back in 2021. 2021, right in the, I think it's in the middle of the prostate, of the COVID outbreak. All right, so a still small voice continue to, nudge me. Rowan, you need to go and do your prostate test. And as you all know, men are not really in that of a rush to do that prostate test. But I could not secure that voice in my head. Rowan, you need to do your prostate test. And so one day I was at work and I saw the nurse coming with another lady from the cafeteria. And I said, nurse, I would like to do my prostate test. And she said, true? Come on, here is the doctor. We went back to the the health department, and the doctor pulled my file. While looking through the file, this strange look was on her face, and I said, "Doc, what the problem?" She was looking at my last medical that I did, and the blood result wasn't looking, as it should. It was at 6.0, to be exact, 6.0. Out of abundance of caution, she recommended me to Dr. One, and I make an appointment. I went there, I do the initial test. He recommended a biopsy. I did the biopsy, and the result came out. There was cancer on the left side of my prostate glands. Hope I get that right. I did additional tests. There was one test that I had to do to see if the cancer had spread into my bones. Thanks be to God, it wasn't in my bone as yet. People might say to me that, "Ron, were you feeling any pain? Were you seeing any signs?" And I just want to say that I used my prostate cancer experience to start a mini ministry, so to speak. Were you seeing any pain? Were you feeling any pain, seeing any sign? No, but that still small voice, the voice of God, was talking to me. You need to do your prostate test. I was recommended to Dr. Greaves. I think he's a part of the panel. And the plans were put in place for me to do my radiation treatment. The radiation treatment lasts 8 weeks. And 8 weeks, Monday to Friday. And I went in, did the treatment. But during this treatment, my wife would tell me that, "Why, Rowan, you walk and you tell everybody that you have prostate cancer." Yes, I tell as much people as I could find, friends and loved ones, because I see this as an opportunity. I know it was within God's providence. Something was happening behind the scene. And so because I have already let so many persons know of my illness, months after they would come back to me, "Rowan, everything," and I get the opportunity to witness and said, "God has come through for me. He has healed me." And as good as Dr. Grieve and his team were at the time, I'm quite sure that God's handiwork was on display. There's so many other stories within that experience, the cost, and those who know the treatment for prostate cancer. It's over $3 million. I received my prostate cancer diagnosis 2 days after I got my redundancy letter. 2 days after I received my redundancy letter. And I was saying, how can this be? I have worked over 30 years and now I'm in possession of a redundancy check. I'm going to have to just with the snap of a finger, everything will go into this treatment, over $3 million. I went to my nurse at my company. I received 1 month to clear up my desk. I received redundant. And while I was there, the treatment was to start after the redundancy date. I went to the nurse, asked her, seek to find out if they would still cover the cost. She said, "Boy, Rowan, remember, you are no one redundancy. We are not responsible for you again." But I remember one day I was asleep and my phone rang, and it was a nurse. "Rowan, we have met as a L team, as we have decided that because of your contribution to the company over the years, we will cover the full cost of the treatment, $3.9 million. And I must say, thanks be to God. But this prostate cancer journey, it has allowed me to testify of the goodness of God. I said I've developed a ministry out of it because from time to time, people would call me from as far as the USA. Friend would call me, "Rowan, can you just talk to my brother for me? He was told that he had prostate cancer and it's a death sentence for him. Could you just tell him that there's hope?" And I would get the opportunity to talk to that person. I have family members who would say, "Talk to my husband for me." What made the difference? What made the difference on this journey is that when you know God, you see things from a different perspective. I was very confident while going through my treatment, confident that whatsoever the outcome would have been, all things work together for those who love the Lord. So I wasn't confident that I would have been cured or healed. I was confident that whatever the outcome, all things work together for those who love the Lord. I have friends who said, "Rowan, I have never seen you being disappointed." Never. No, I'm not easily disappointed because I know that whatever challenges I am facing, whatever the result, all things work together for good for those who love the Lord. So for those who may be facing the same issue, prostate cancer, it's not a death sentence. It can be cured, it can be overcome, but the answer is in early detection. And I thank God, I thank my church family, I thank my elders. I remember my elders calling me in the middle of the night and praying for me and my wife. We were sitting in the middle of the bed at the time and they were praying for us. So when you have the support, when you have a support unit around you, your church family, it makes a big difference as to how you face these challenges that you make, these storms, if I may put it that way, that you make face from day to day. So I have turned my out of bad comes good as far as I'm concerned. As again, let me repeat, my favorite Bible text, all things work together for good for those who love the Lord. Whatever the outcome was, I was quite sure, I was confident that God's providence would have been on display. Over to you, Pastor Jensen.
Thank you so much, my brother. Wonderful testimony there. And us as men, we should at least learn from Brother Ron. All right, to take us through the program just now is Elder Kwame, a team member from the men's ministry department, the conference level. He's quite supportive. One who can handle himself well as it relates to moderating programs. And so the Kwame is one of the elders at the New Kingston Fellowship Church, and one who certainly can do the job good. So, Sir Kwame, I turn over to you now, and of course you'll outline to the folks the time and so on. Over to you.
All right, thanks for the words of affirmation there, Elder. I also want to thank Brother Rohan for his testimony, and just to welcome and to thank the leadership of the East Jamaica Conference, spearheaded by the president, of course, Dr. Merrick Walker and team. Thank you very much for seeing it fit to put on such a particular program, especially seeing that this month is Prostate Cancer Awareness Month. So just to welcome all those of you who are online, whether it's via YouTube or in the Zoom room here, just to walk you through what we're going to be doing. It's the Prostate Cancer Awareness Forum, and it's a collaborative effort between the men's ministry and the health ministry of the East Jamaica Conference of Seventh-day Adventist Church in Jamaica. And that's just in case you are not sure, if you're on YouTube particularly. So I am your host, I am Kwame Thomas, and I'll be moderating this. And the aim of this particular discussion is to raise awareness about prostate cancer and to discuss some effective detection and management strategies and to see how we can actually cope with this thing. Because while we're on this side of life, we most likely will fall prey or victim to one of these illnesses. So it's necessary for us to at least know, because an abundance of information tends to lead to a lack of fear or a minimization of fear. So our panel, our esteemed panel, will include Dr. Venslow Greaves. He is a radiation oncologist. We'll also have Dr. Robert French, a general medical practitioner, and Mr. Baron Anderson. He is a cognitive behavior therapist, and one other individual who is going to be contributing significantly to the discussion is our own Pastor Leonard Steele. He is the health ministry's director of the East Jamaica Conference. And we'll be doing this discussion for about 48 minutes, after which we'll use the rest of the time, about 27 minutes, for questions and answers. So we're just going to be starting to look at the importance of screening, risk factors and demographics and things of that particular nature. So, gentlemen, welcome. And I hope that we will be having a very insightful discussion, because you are all subject matter experts in your respective areas. So I'm looking forward to a very, very good discussion. Elder French, not seeing Elder, okay, Elder Greaves, Sir Anderson, and Sir Steele. So what I'll I think it's prudent for us to start with the importance of screening. How we just heard from the testimony a while ago that was given by Elder Gordon. How crucial is early detection and as far as survival rates are concerned for prostate cancer patients, and what role does, say, PSA tests will play in achieving this? I think I should throw that question to Dr. Greaves.
Good evening, everyone. Let me thank the East Jamaica Conference and Pastor Johnson for inviting me to this panel discussion on a very important subject matter, that is prostate cancer. I just want to extend my sympathies, though, to the deacon and the other gentleman who committed suicide. And it brings to fore that men don't like to confide or to divulge serious problems that they may be undergoing. But in reference to prostate cancer, and Pastor Walker, you mentioned some things that were important. We need to be each other's, I'm talking about men, we need to be each other's keeper in this regard. And later on, when we come to dealing with the psychological aspects of prostate cancer, I will probably come back to this part of it. But screening, right? What is screening really? Screening is used to detect any disease that may not be manifesting itself as yet in the form of symptoms. Now, in the vast majority of cases, we're talking about over 70% of cases of prostate cancer, you feel fine. There are no symptoms whatsoever. Now, symptoms that some men may have, such as frequency of urination, burning when you pass the urine, having to pass the urine very frequently at nighttime, low back pain, these may or may not indicate prostate cancer. So we need to find a way of detecting cancer if you have it at an early stage. And the early in the 1980s, the PSA was discovered. The PSA is a blood test, and prostate-specific antigen is really an enzyme that is secreted by both benign prostate cells and malignant prostate cancer cells. But it only rises to a certain level in the bloodstream in the normal patients who don't have prostate cancer. But if it is elevated above a certain level, and we use a cutoff point of 4, right? If it's elevated, it is room for concern. And the studies have shown that if it's elevated above 4, between 4 and 10, there's a 25% chance that you may have prostate cancer. If it is more than 10, it rises to about 50% chance that you may have prostate cancer. Now, what if it's below 4? Right? If it's below 4, there's still a 15% chance that you may have prostate cancer. So we use this as a screening test. It is not perfect. So you have to use it along with digital rectal examination. And by digital rectal examination, I mean a finger that is inserted, glove finger inserted into the man's rectum to detect what and how the prostate feels like. So these are the two commonest types of screening tests that we do here in Jamaica. There are other tests that are done elsewhere, but the main screening test that we have here in Jamaica is the PSA and the digital rectal examination.
All right, thanks much, Doctor. What I wanted to find out, though, you stated that if you had whether malignant or benign things on the prostate, then that would cause an elevation in the secretion of PSA. But what if you have none? Is it that everyone releases that prostate-specific antigen, or is just persons that have either a malignant or a benign growth?
Okay, you have to take the entire picture into context. If you're dealing with a man, and the Jamaica Cancer Society recommends that we start our screening tests for prostate cancer at age 40, because
But
we
it was 50.
Right, they have dropped to 40 because we fall into a high risk group. The Afro-American population in the United States are a high risk group, and we come from the same African ancestry, and it is felt that we need to start our screening tests a little earlier, right? And especially if you have a family history of prostate cancer, you should really start it early. But dealing with the man now, right? If you are screening a gentleman, he has a strong family history, or he doesn't have a family history at all, but he has factors, he's obese, high stress level, you may want to do a PSA as a preliminary test to see what the baseline is, what his baseline PSA is. Now, if it is elevated, it depends on how high it is elevated, right? If you may want to repeat, and if you're doing a PSA, we recommend that you don't ejaculate. You don't have ejaculation within 48 hours. You don't get a rectal examination. You don't do a colonoscopy. You don't ride a bicycle, because all these things can massage the prostate and cause abnormality. It causes a falsely elevated PSA. But if you've done all those things and your PSA is elevated on 2 or more occasions in the below and in the 4 to 10 group, you need to be referred to a urologist to consider doing a biopsy. It may not be malignant. It may be just, this prostate may just be inflamed, but out of an abundance of caution, the urologist and you will decide whether a biopsy is necessary.
All right, so I want to include the psychosocial impact as well as the other ones in the discussion. So, Brother Baron, what are some of the most common emotional reactions that you might get to a prostate cancer diagnosis, and how can healthcare professionals better support men during this particular point in time?
Well, you know, how the mind is made up, it's not any different from any trauma that you may experience or any information that you would have you would get. So the normal shock, you know, the emotions of shock and fear and confusion is what you will experience. You know, some persons even go as far as into denial, which of course denial is not necessarily a common one. So it would be the shock, it would be the fear, and it would be the confusion. And so what we advise is that when you get into that, the advice is to take your time to process the information and to seek clarity from your doctor. As a matter of fact, let me quickly just mention that yesterday we went up into the hills that Pastor just mentioned, you know, to talk to the brethren, offer a little bit of support and brief counseling to the brethren. And I was able to ascertain some information based on discussions that I just had with the brethren and persons who are very close to the deacon.
And what I got was, okay, so the deacon was living in the States and decided that the States wasn't really where he wanted to be. He wanted to come home. And of course, before he had left, he was the farming was what he was into. And the farm was doing very well. But of course, while he was away, Beryl came and destroyed the crop and made a mess of the farm. He was in dialogue with his mom, who was living on the premises, and because she wanted her son to come back to Jamaica to be a companion to her, she told him, well, the farm got a little hit, but it's not nothing that can be corrected. It's gonna be fine. So when he came back and he went to the farm wasn't really what he thought it was. So when he saw it, it triggered a little bit of shock there. It triggered a lot of fear there, and it triggered a lot of confusion. So as a result, he became very low, and there was this sadness that came over him. And of course, the sadness that came over him, Dr. French, you can clarify this, you know. So he went to a general practitioner, Dr. French. He went to a general practitioner, and the practitioner, of course, his heartbeat was good, his vitals were fine, but he was not mentally fine. And so he probably gave him a prescription of something, and he went to, but was of course feeling the same way, because what he probably needed was dialogue, somebody to support what he was experiencing mentally and not physically. So sometimes when we feel sick, we run to the, if your eye hurting you, your eye giving you trouble, who you
Yeah,
go
go
to?
to a mechanic.
Go to the GP. Eh? You go to the ophthalmologist, right? And so when after having conversations with them, I realized that you know, probably he went to the wrong person. And so we tend to have a tendency to say, boy, I'm supposed to be spiritually sound, and this happened to him. But we don't want to go there. We don't want to judge that. You know, what we want to do is to encourage persons to consider talking to a trusted family member or a friend for that emotional support that is necessary. Get complete understanding of the diagnosis. Ask the doctors key questions. What stage of cancer is it? Is the cancer slow growing? Is it low grade or aggressive, high grade? What are the treatment options? Understanding your Gleason score and your PSA levels. You know, these will give you an indication of how aggressive the cancer is. And the testimony that we listened to previously would have given us a good understanding. So when the brother, he was very positive about his relationship with God, and despite what the result was going to be, he had a positive approach to the whole thing, and I thought that was absolutely wonderful. So, you know, I think I've talked about it a little there,
Right.
but if there's anything else.
Sure, no problem. So,
Yeah.
so Dr. French, one of the questions that came to mind when Byron said something about well, when he was going through what he just spoke of, was family history, and what are some of the genetic markers that we as men should be aware of as far as prostate cancer is concerned?
He's muted.
You're muted.
Still muted. Still muted.
Yes, I'm on. Okay, good afternoon, fellow panelists and the public at large. There are several things that we need to address. Let me just address the thing about going to the general practitioner or not first. The fact of the matter is that the ophthalmologist is not likely to see you unless you see the general practitioner first, because the general practitioner does the screening. to decide who goes where.
Oh, so
Now,
it's like a triage.
yes. And and in the instant, let me just quickly elucidate the parameters that would have surrounded the instant case of suicide. If the gentleman had suicidal ideation, in other words, expressed to the doctor or family member that he was thinking that way, then he should go to be sent to the hospital on suicide watch. Let me just say, depression is a very, very serious problem. Severe depression, suicidal depression, depression can cause suicide in anyone. So it is not that this man was less spiritual than anybody else necessarily. The fact is that if you are depressed enough, suicide comes up as an outlet for severe depression. It does not mean that the gentleman was necessarily misdiagnosed. Perhaps he was even put on antidepressant medication. I don't know. We don't know enough here. But even when you're put on antidepressant medication, there are some instances where the fact that you're just starting to treat the depression might even accentuate the occurrence of suicide in the early stages of treatment. Let's leave that as is for the time being. You talk about factors that would have influenced the development of prostate cancer, markers. Now, let me say that there are some markers that are used to point us towards seeking further testing. If you have a family member who had breast cancer and strong family history of breast and ovarian cancers, then such persons should get early PSA testing, because there is some relationship to the BRCA1 and BRCA2, called BRCA genes, that occur in certain families where mother, daughter, aunt, sisters are having breast cancers and ovarian cancers, and the brothers and of these same people or progeny of these same people have a higher risk of prostate cancer. There are other tests there's one called HOXB13 that is tested for elsewhere. It's not tested for in Jamaica. However, screening, because we don't necessarily have the most sophisticated test, the screening is the most useful tool. And although the PSA is so emphasized, having a normal PSA does not say, as Dr. Greaves said, there's still a 15% chance of having prostate cancer. So the PSA by itself is not proper screening. The digital rectal examination, because when you do the digital rectal examination, you can feel tumors, bumps, or hardness of the prostate gland, which will then point you to say, get further checks, such as an ultrasound of the prostate, and in some instances, even MRI. I have seen a recent case where I examined the person. He had no symptoms. He just came in for testing, found that the prostate was quite small. It was not an enlarged prostate to any great degree, and it had a tumor in, and I sent him for the PSA. The PSA was normal, but I still sent him to the famous urologist whose name was mentioned, and he found the same tumor that I felt, and he biopsied him even with the normal PSA, and it turned out to be cancer, and he was treated. So getting this routine screening when you're over 40 years old is important. Now, also, if the results are between 4 and 10, you don't wait again until a full year. You will repeat the test within 6 months. And as Dr. Greaves said, you make sure that no sexual activity would have occurred within the 48 hours prior to the test. And that will be helpful. You asked about PSA earlier, and I will tell you what the prostate-specific antigen. It is a protein. which is in the semen, which allows the sperm to survive. It's almost like food for the sperm once the sperm has left the man's body. And so, because it's an illness also, not related to prostate cancer, where the sperm dies too quickly. Normal sperm on entering the female lives for at least 48 hours and sometimes up to 5 days. So, but this prostate specific antigen, that protein, literally keeps the sperm alive once it has left the body. So it does have a purpose. But produced, as Dr. Greaves said, by normal cells and cancer cells. But when it's elevated, then you can know that there's something going on wrong. There's another test called the free PSA test. So you have total PSA, which is between 0 to 4, and you have the free PSA test, which is part of this, which would fall under the 4. And if the free PSA is high relative to the PSA, then that is a sign that you have more benign, non-cancerous enlargement of the prostate if the prostate is enlarged. So a higher free PSA relative to the total PSA is a good sign. So you have your total PSA, your free PSA, and your digital rectal examination as the main screening tools, followed by ultrasound and MRI in Jamaica for finding out about enlarged prostate and cancerous prostate.
All right, just before I put Pastor Steele on the spot though, there was a statement, a question was asked, and what I want to find out from that, the idea of BPH or an enlarged prostate, benign prostatic hyperplasia, is that are persons with that condition at a higher risk for prostate cancer, or just because it's enlarged and it's benign, then no, there's no issue for them to be worried of?
There is no significant relationship between a benign enlargement. In fact, many people who have prostate cancer don't present, as Dr. Greaves said, would not present with symptoms at all. When you have benign enlargement, you have an enlarged prostate and you get the symptoms of an enlarged prostate, which is usually difficulty in passing urine, and sometimes a total inability to micturate or to urinate. That's an acute retention, or it can be chronic, where when you void or pass your urine, it is not complete, and you get a gradual buildup in the bladder, and you can get infections, and you can get thickening of the bladder and diverticularity of the bladder, and back pressure into the kidney, hydronephrosis, and damage to the kidneys, and so on. That's a cascade of events going backward from the prostate up to the kidneys. But that's benign enlargement. Many people, as 70% of people with prostate cancer, have no enlargement at all. That is what Dr. Greaves just told you. And therefore, there's no significant relationship between the benign enlargement and the cancer. Sometimes they do occur together, and sometimes even after the benign enlargement has been treated by an operation, a prostatectomy, because the benign enlargement and the cancer usually takes place in two different areas of the gland. The gland is capsulated like a guinea. So there's an inner part, a core, and then there's an outer part. And that outer part is where the cancers occur. The inner part is where you get the benign enlargement. So even after surgical enucleation of the prostate or a transurethral resection of the prostate has been done, the prostate has been cleared, people can still go on to have prostate cancer, because in effect the one gland is operating as two different glands. The inner part does the benign enlargement, and the outer part usually produces the cancer.
Okay, all right. Pastor Steele, so in your station as Health Ministries Director, one of the things that I want to throw at you know is, do you think, from where you sit, do you think that there is a link, any clearly discernible link between prostate cancer and, well, just cancers generally and lifestyle? I know the answer to that, but I want you to say it and tell us what your views are as it relates to that. You're muted.
Yes, thank you very much for the opportunity to say something on this. Let me say good afternoon to everyone. Like every other diseases that we are battling with today, lifestyle really plays a very, very crucial and important role in most of these diseases, especially as it relates to prostate cancer. And we discovered that there are several factors that, according to research, that has shown that has contributed outside of genetics, have contributed to the whole matter of enlarged prostate. And we, as I've said, the same criteria that I would use for other lifestyle diseases, I would also use it for the matter of prostate cancer or enlarged prostate. It has been discovered that getting adequate sleep restores the body mentally and physically. And if you skip your sleep and you do not get enough rest, the body cannot adequately repair itself. And hence you find that it is not able to resist or to combat some of the diseases or problems that may also lead to the virus infection in the prostate. Not only that, physical activities, physical exercise, it is proven that physical exercise make a big contribution to the whole matter of even controlling, to some extent, the rate, the size, and the growth of the prostate. That food, the very food that we eat, research has shown that persons who continue to consume a lot of flesh food, especially red meats and dairy products, has some impact on the enlargement of prostate. And they have shown where person who goes on a plant-based diet tend to somewhat minimize or control to some extent the growth and enlargement of the prostate. So we have discovered that if one really take into control the way he eats and the way he drinks, the type of food that he eats, alcohol, if he consume a lot of alcohol, or if he continues to smoke a lot of tobacco, and some of these risky behavior, it has an impact, a definite impact on the prostate. And so we tend to try to encourage people to stay as much as possible on a plant-based diet. Not to say that persons who are on a meat diet doesn't necessarily have some control where that is concerned or minimized. But the fact is, the overwhelming research has shown that eating your vegetables, your fruits, and the plant-based that God has given to us from Genesis chapter 1, verse 29, your nuts, your grains, and so forth, has really contributed tremendously to the slow growth of the prostate. So
what we're saying then is not that you won't get or you can't
No.
get if you're a vegetarian or vegan. It's just that we're saying that it minimizes significantly the
Yes.
instance or incidence of you getting it.
that's right. That's right.
All right. So what I want to throw to the rest of the panel though is that we heard from Dr. Greaves's statement that Afro-Caribbean and Afro-American persons are of a higher risk for cancer or for prostate cancer. Why do you think that is, and are there any prevention strategies that can be better tailored to this particular demographic? And it's not just for you, Dr. Greaves, but it's for everybody because you might have access to the information. So what you can start though, Dr. Greaves.
No, why Afro-Caribbean men and Afro-American men have a higher incidence of prostate cancer than their colleagues in the other ethnic groups? I don't think it's quite known. But we do know that there's a higher incidence of obesity in Afro-Caribbean men and Afro-American men than their other counterparts. We also know that their diets may differ somewhat, and as Afro-American men, Afro-Caribbean men tend to like the diet that
Right foods.
predisposed to prostate cancers, like fries, oils. And in Jamaica, we like to see our meat swimming in oil. So it makes you salivate. Also not good for the prostate. And then the nutritional aspect is very important when it comes to, and I think they have done studies that have shown now that a higher instance of mutations occur in Afro-American, Afro-Caribbean men that predispose them to developing prostate cancer. So, but let me mention here at the outset though that most prostate cancers are found in men with no family history whatsoever. I mean, they think about 15 to 20% of men with a family history will have prostate, has a history of prostate cancer. There's a 15 to 20% instance of a first-degree relative with prostate cancer. But the vast majority of men don't have this genetic risk.
And for those, you said first degree family member, we just want to clarify for those who might not know, we're talking about a close skin, a parent, a sibling.
A brother, a father. Brother or father, first degree. Right?
Or son.
Or son.
Or son.
And this, but the whole point of the matter is so that I think we live in an environment that fosters the development of prostate cancer. If you're coming from a low incidence country like Japan, right, or India, and you come to Jamaica to live, and you assume the lifestyle of Jamaicans, they've found that the first generation relatives, first generation, have almost the same incidence of prostate cancer as the father's generation who migrated, right? So it is the fact that we have this inbuilt tendency somewhat to develop prostate cancer, and then if you put diet, lifestyle, obesity, lack of exercise, stress, and whatnot together, all these factors will come together and cause prostate cancer.
All right, Dr. French, so that your mic is open.
Well, you mentioned that before before I don't get the opportunity to say this. Researchers at the UWI had found out that people who consume within Jamaica a lot of avocado, what we call pear, avocado pear, tend to have a lower incidence. I don't know how concrete the research was, but I recall about 8 or 9 years ago, the government saw it important to bring all the practitioners to the conference center to tell us of this research, that a diet high in avocados seem to reduce the incidence of prostate cancer in Jamaica. I must also tell you that, yes, abstaining from dairy and red meat, as Pastor would have indicated, is useful. And remember, there are certain foods also that tend to reduce the incidence or the growth of prostate cancer, such as the lycopene from cooked tomatoes, sweet potatoes, and pomegranates. These are all anti-cancer plant-based foods, plant-based foods. So therefore, we should seek to increase the amount of those things in the diet, especially because we do not know exactly what causes prostate cancer.
All right. So I came across a study sometime, well, 2 years ago, I think, where it says 54% of Jamaicans are either overweight or obese. I thought I would have assumed that the figure was significantly lower, but apparently PAHO has other stats to show us that I was wrong. How does these things, as in overweight or obesity, contribute to prostate cancer and any other comorbidity that we might be suffering from?
The fat in the body, especially abdominal fat, is not innocent. That fat produces chemicals that suppress the immune system, that increase the development of blood vessels. And by so doing, when the cancer cells do form, because you are already obese, and because obesity causes what we call angiogenesis, that is the production of blood cells, because the fat itself requires increased blood vessels, and these chemicals that are produced to cause the growth of blood vessels to the fat also influence the growth of blood vessels in all other tissues, including when the person is diabetic, including the retina, and but wherever cancer cells occur, because we believe and we are told by researchers that cancer cells form in almost everybody, almost every day, but the immune system is able to suppress them and kill them. Well, when the immune system, obesity reduces the ability of the immune system to do that, and therefore, when one is overweight, there is a tendency for cancer to occur, and it does not just prostate cancer, breast cancer, and other forms of cancer. So obesity is a risk factor for cancer because it suppresses the immune system and it causes angiogenesis or blood vessel growth.
All right. Thank you.
There is
Warren.
Yeah, man, there is something that was brought to our attention in the beginning through the testimony of the gentleman who said that when there was a voice in his head that persuaded him to go and do the test. And that I thought that was very, 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 very eye-opening, but very different from how generally or men especially respond to testing as it relates to cancer. A lot of us are reluctant to go and do that test. And I think Brother Greaves and Dr. French did did excellently in explaining to us what the food part and that kind of thing. But in terms of the mindset of our men, in terms of how they respond to getting the test done and something, I just thought that maybe I should share something briefly as it relates to that. Now, our men have a fear of discomfort or pain, you know, when they think about getting a test done. And I must hasten to say that based on what Dr. Greaves mentioned, is that has been eliminated. So we shouldn't really be fearful of that kind of pain and discomfort that initially when my dad would say to me, this is what he experienced when he went and did it, fingering up this, and that wouldn't encourage me to want to do it. As embarrassment or stigma, so you know, societal perceptions, there can be social stigma around the idea of rectal exam, particularly among men who may feel uncomfortable with the vulnerability required during the procedure. Fear of diagnosis is also something that prevents persons from wanting to do the test. They'd rather not to know than to know. Lack of awareness and understanding. This kind of forum is excellent as it relates to sharing with some of us, you know, because we might not fully understand the importance of prostate exams and might underestimate their necessity, and especially if they don't experience the symptoms that we were talking about. And concerns about sexual function is something that in my own observation, the conversations that I've had with folks, there's a misconception about sexual health, because some men fear that the prostate exam could somehow affect their sexual performance or their masculinity. So there's a misconception that the exam itself or subsequent treatment, if an issue is found, could lead to impotence or loss of sexual function. And it's something that we should not hesitate to have a conversation about. And then we talk about the perception of the vulnerability, you know, it won't happen to me, mindset, that kind of thing, you know, but it can happen to anyone. So we encourage persons to do the test.
Anyone with a prostate.
Huh?
Anyone with a prostate. So
yeah,
so,
you know, but all of us kind of say, well, guess what? I don't feel no symptoms, so you know, I'm not going to get that test done. That is a common conversation that I have with the guys out there, the young men that I talk to, that kind of thing, and so on. And
I think what was instructive though, Baron, was the fact that from the testimony we heard that there were no symptoms, and you still heard the small voice. But then the question that I'd want to throw out, especially to Dr. Steele in his capacity again as health director, is how, and this is based on what you had just said, Baron, is what can we do as a conference, as a church, to address the stigma that the men face? Especially when we are diagnosed, or when they are diagnosed with prostate cancer, and how we can dissect the two to show that, hey, it doesn't mean that there will be there might be, but it doesn't necessarily mean that there will be negative sexual health or something, your masculinity will be compromised because you have become vulnerable or so. So I'll take your viewpoint from that first, Dr. Steele, then go to Baron, then I go to the two other healthcare professionals.
Yes, that is true. There are some men who being diagnosed and living with prostate cancer, the moment they hear about prostate cancer, for them, they think that the world has ended. And it can be hard to deal with emotionally as well as physically. And one might feel very scared, they may be worried, stressed out, and even angry. And it is very important for this support. The brother spoke about the support of his family, and that is key. Whenever one is diagnosed and discover that, yes, this is what is happening to me, or even just a matter of the enlargement of the prostate. And there are some men who become scared and worried and begin to feel that this is the end for them. They're going to get cancer and so forth. So what we have been doing as a department is that we have been in the past, and we continue to do it, is to have these seminars like these and workshops with our men. And I'm glad that Pastor Johnson has joined with me in this program, this quest, because the fact is that we need to educate our men more. And if we have more forums like these, let's say in the churches or men's department, you know, inviting us to come in. We have many physicians and many health workers and persons, health professionals. We have a health professional association. We have a Adventist Health Volunteer Association. We have resource persons in the church. Thank God for that. We are blessed who will be able to assist in educating, disseminating information to our men and informing them that there is hope. And the fact is, as you have said, Mr. Chairman, that the difference between the Adventist men and maybe others is that the Adventist men have hope. We have something living for, and the effect may not be as devastating as somebody who doesn't know about Christ. And so we are willing to work and to go wherever we can to help our men in the churches to make sure that they are informed about the signs, symptoms, whatever it may be, to help them to be better educated on this matter.
May I, Mr. Moderator?
Sure, you can. Yes, you can.
Thank you, Dr. Steele, for your input. I just want to say that we cannot leave here and don't accept that the treatment for prostate cancer, as is the treatment for most illnesses, does come with some amount of risk and some amount of side effect. So let us not give the public the idea that it is totally risk-free when you are treated. However, the risk of side effects far less. The benefits of getting treatment is far more than any side effect or risk that you might come to, because untreated prostate cancer, although in most instances slow growing, in some instances can be very aggressive. Okay. And in that case, you get spread of the cancer to the bone and lymph nodes and even to the brain. And in those instances, when you get this cancer spread, it leads to an agonizing death, you know, wasting away, as in occur with most cancers, loss of appetite, weakness, bone pain, and all of urinary symptoms in addition, and all of that leading to death. So yes, there are some side effects to treatment, but they are far less than the ultimate death that can come when an aggressive prostate cancer is left untreated. Note that I say aggressive because there are instances where someone might even have prostate cancer, but it is so low grade and they are so advanced in age that you can literally wait and watch, or you can test and monitor, and without aggressively treating, and the person can live a normal life even with the cancer. So it's not a death sentence by any means, and early detection means that you can have a complete cure. Some people who are advanced in age do not have to be treated at all. You wait and watch, or you monitor and watch, and monitor and wait. And by so doing, the person can live out their normal life, dying at a ripe old age, and without having to be given any form of treatment in some instances.
So just to add to what Dr. Steele just mentioned, and what the other professionals mentioned earlier, education and awareness. So when we have forums where we can explain the importance and simplicity of the exam, can help men understand the early detection saves lives. Encouragement from loved ones, family members, friends, encouraging men to get the exam can make a difference and will make a difference. And having a good doctor-patient relationship, a respectful and reassuring approach from our healthcare providers can help men feel more at ease, because I think there's a real stigma out there as it relates to prostate exams and that kind of thing. And these exams are absolutely crucial for early detection of prostate cancer and other issues, and breaking down the barriers of fear and discomfort and misinformation can encourage more men to prioritize their health. I think that is absolutely important. I think forums like these are absolutely wonderful. And of course, when we finish here, we don't stop here. We can take it a little further as it relates to even on our boards at church, or what you call the notice boards at church.
Yeah.
We can have posters that talk to the importance of early detection. We can have information where people can know, okay, we can always call up or go visit Dr. Greaves, but then a lot of us sometimes we think we can't afford it, we really can't afford it. So if we have Pastor Steele, if we have more information where people can go and get it at a reasonable cost or free of cost, that kind of thing, that's useful too, that kind of thing. But if we can minimize the fear factor that most men experience when they think about prostate, that would be taking it to a wonderful step.
All right. So just before we ease into the Q&A, I want to hear from Dr. Greaves now.
Just let me mention one other thing in addition. Sometimes we may have problems with determining whether or not to do a biopsy. A biopsy is not a walk in the park, and it comes with certain risks. And there's a special test known as a PCA3, which we can check for in the urine after massaging the prostate. And if this level is high, then the chances that you have prostate cancer is also very high. The other thing is that all prostate cancer is not the same. There are slow-growing prostates and there are aggressive prostates. And we usually try to classify prostate cancer by something known as a Gleason score, right? And the Gleason score is something that is worked out by looking at the type of cancer cells that is found in a particular biopsy. If they closely resemble the ordinary normal prostate cancer cells, they have a low Gleason score. If they don't resemble it at all, they have a high Gleason score. And the higher Gleason score prostate cancers usually are the ones that behave aggressively and will need intervention as far as treatment is concerned. Now, in terms of treatment, which we have not touched at all, right? That's a different ball game, right? And I think you owe it to yourself if you have if they have made a diagnosis of prostate cancer, that when you go to your professional urologist or radiation oncologist, that you are aware of the options that you have, right? The option may just be to watchful waiting if you are what we call a low-risk prostate cancer. The problem with the watchful waiting is that you have to be committed to doing a PSA. And if the PSA starts to move, you have to be committed to doing another biopsy, because prostate cancer may not remain the same all the time. It can transform, right? If you have aggressive prostate cancers, now the main options for treatment is surgery or radiation. Now there are different side effects depending on which route you will take. And you have to be comfortable when you're consulting with your urologist or radiation oncologist, which one you feel more comfortable with. I'm talking about the side effects. But I will give way here because I know that time is of essence.
All right. Thank you very much, gentlemen. So how we'll do, I'll just search through the comments. I'm not sure if there's anybody to monitor YouTube because I'm not on YouTube directly. I'm on Zoom, so I didn't want to have any cross communication there. But somebody could look at that and field the questions to me. But separate from that, though, I'm seeing in the chat whether or not, and I've heard it in the past, that eating too much ackee might lead to that. That's one. Eating too much okra can lead to that. Eating too much pepper or spicy food, because and I guess that's stemming from the fact that Jamaica has at one point in time recorded the highest instance or incidence of prostate cancer in the world. So I wanted to find out from you, as do the persons here in the question and the Q&A section, whether or not these are some contributing factors to prostate cancers, or we're not so sure.
Eating ackee at one time in the 70s and into the early 80s was being considered as a significant risk factor. However, there has been no evidence to show that eating ackees increase your risk. That came up because, for instance, we in Jamaica eat ackees, and people, for instance, in West Africa do not eat ackees. But one of the things to remember is that our life expectancy, our age range is different from that in West Africa. The life expectancy in West Africa used to be and continues to be much less than the life expectancy in Jamaica. And as you recognize, the highest incidence of prostate cancer, although it starts usually starts in the 40s, can start in the 40s, the highest incidence occurs over age 65. So because our people tend to live beyond 65 years old, the prostate cancer is seen more compared to, say, an African population that has a life expectancy of 55 or so. Okay. But eating ackees has not been shown. But remember, even if something is good, you should be temperate in good things, because ackee is fatty food, and it's totally plant food, but it's fatty food. And if you increase the amount of fats, but not only fats, because fats are bad for us, but sugars are even worse. And the obesity epidemic is not so much related to the consumption of fat, but the consumption of sugar. And sugar is a high risk factor for all cancers. So we should recognize that we must be temperate with ackees as with everything else. But ackees have not been shown to increase the risk of prostate cancer.
Someone was asking a question. was asking a question that they did the biopsy, and they thought that doing the biopsy was a mistake. It caused the cancer, the prostate cancer, to become more aggressive. If that can be true, but that was what the person said in the YouTube.
There's no evidence that is the case or that has ever happened. But I would just like to go back to the ackee. I think the preparation of the ackee, again, swimming in oil, right, and butter and the fish and whatnot. We don't know what other ingredients are there. They may do something to give people the impression that it may have something to do with prostate cancer. Again, my colleague, Dr. Frank, said everything in moderation. And I don't think the occasional eating of ackee is a problem.
So, so Dr. Michelle Hamilton is asking if we could elaborate on the studies that show a correlation between men who have had multiple sexual partners over the years having increased risk of prostate cancer.
I would say that there is no evidence to show that there's an infective agent that is involved. What a recent study, though, that came out of, I think it was Germany or one of those places, showed that if men ejaculated more than 25 times for the month, it lowered the incidence of developing prostate cancer. So the evidence here is conflicting. But I don't know of any evidence that multiple sexual partners increases the incidence.
All right. Are you able to speak?
Can
Sure.
we
Sure,
can
Dr.
we say though that multiple sexual partners might well kill you before you have the chance to get prostate cancer. So that is not advised at all.
So that's risky in and of itself.
Risky behavior, yes. We're talking about hepatitis C, HIV, and human papillomavirus, leukemia. All those things, I mean, adult onset leukemia, all those things are sexually transmitted, and they have a big chance of killing you before you're 65. So to get into that high incidence area of prostate cancer.
And just one last thing before you continue. If we Google it, we will find that there's a Glover study that showed that Jamaica had an incidence of prostate cancer of 304 per 100,000. There are problems around that study because the analysis was done even on post-mortem specimens. They look at men who have died from other causes, and they look at and they analyze the prostate, and if they found prostate cancer, that was included into the group. So there are problems of whether or not that figure should really be accepted. The cancer registry at the University of West Indies has consistently shown that a figure close in between 78 to 100 per 100,000 is closer to the figure that we experience here in Jamaica. But because prostate cancer is not a reportable disease, we don't really know the true incidence in Jamaica.
So what we're saying then, from your statement, Doctor, is that epidemiologically, we are not necessarily so sure about the truth behind that particular study then. So we're not sure how many or what's the real instance of it.
You might have noticed that on the chat that Dr. Martin Franks, who is an epidemiologist, who has worked many years with the UWI and I think now works with NCU, has said categorically that the study was not properly done. So we have to take that with some caution. And Dr. Franks is a credible source.
Wow. All right. So one of the things that we also wanted to find out, on average, what are the costs? Someone asked that question. Someone who's diagnosed with prostate cancer, what is the cost likely to be for some of the various treatments that you are able to speak to? Anyone of you?
I work at a private center, and let me make a disclaimer here. I don't own that place. I don't own that. And the cost for a 5.5-week course of radiation will be between $3 and $4 million Jamaican dollars.
And that's covered by insurance?
The major mass, 80% will be covered, I think. Unless you have two health insurances and they join together and cover the entire.
Oh. So And someone also asked, I'm not sure if Dr. French has a statement to make a while ago, so that you inched a little closer to the mic. So if
Well,
you
surgery in general. Remember now, not all cases can be treated by surgery. Surgery in general, reports from the patients that I send on to the urologist might cost somewhat less than the radiation cost, because remember now, surgery is in Jamaica is a more low-tech treatment compared to radiation. The infrastructure is less expensive. But there are other parts of the world where cryosurgery is done. Those things are still like as expensive as the radiation, and perhaps even more. So there are various types of treatment, and depends also on the age of the patient and the stage of the cancer. The very elderly might go on to take monthly injections or tablets, and we're talking about somebody 85 years old or so, or 80 years old, and they will continue to live a reasonably normal life and go on for 5 years or so with treatment with injections or tablets. So the treatment is not the same for everyone. The younger the patient and the younger the patient is usually the more aggressive the treatment, and of course the more aggressive the treatment is the higher the cost. The very elderly, they might elect not to treat, or if they do treat with much less expensive the monthly injection will it's still expensive for people who don't of not of much means, but it would work out over time to still be much less than surgery and so on. And surgery is not always indicated in these very elderly patients.
Okay. So a link was just placed in the group for a Harvard study that was conducted that looked at whether or not there's a link between sexual activity or sexual promiscuity, or more sexual partners, more cancer. That was a Harvard health study that Dr. Michelle Hamilton just placed in the group. The question now that I want to ask, are there any environmental or occupational exposures that can significantly increase the risk of prostate cancer, particularly for men in certain jobs, considering that we're already in a region that has high incidence of it?
There is some link with the use of pesticides and herbicides by farmers. These highly potent chemicals that farmers now use to control pests, that there is some link with the use of some of these products and prostate cancer. And also the suits that firemen wear, they say might have hazardous material in them that might cause prostate cancer. Plus the burning of these various entities when you have a burning building and the fireman is exposed to those fumes, some of those things can be carcinogenic. Those basically are the occupational hazards. Other than that, there is no significant occupational hazard. But some farmers using high level of pesticides, there is some risk of prostate cancer, or some implication of prostate cancer.
Dr. Greaves?
I was going to mention the same thing around firemen. Firemen is increasingly hazardous occupation because of the fumes that and the chemicals that they have to come into contact with, and from some burning buildings. But apart from that, I don't know of any other occupational hazardous risk.
All right. So there's a lot more that we can, but you have spoken to us, the panelists, in terms of advancement in screening technology. But I think more so our primary issue that we have, especially as men here in Jamaica, it surrounds the stigma that's attached to prostate cancer. Because I give my own story. My father, he succumbed to prostate. Well, he passed on as a result of complications from prostate cancer, and it was aggressive because at first it was anticipated that he had three 3 months, 3 to 6 months to live based on where it was, because it had spread to the ribs, the pelvic floor, a number of other places. But when we recognized the symptoms, I encouraged him to go and do, and at that time, we only had information related to the digital rectal exam, and he was extremely apprehensive. And when he went and did that test, the comments and the descriptions that he used for that particular test wasn't something that I can't speak to them now here, because one would be laughing and another set might be saying something else, because it just say that it was unfavorable. And I find that a lot of us as men, we have a stigma around just the exam. And so I want to ask, I know you have said it before, Dr. Greaves, but just for the others, and just in case we have somebody coming on late, after you have answered that, then to Baron, are there any other simpler methods to get that information? That's one for you. And for Baron, how can we help to break down that stigma after Dr. Greaves is finished?
Well, you can do an ultrasound, and you can do a MRI. It's a more expensive way of doing it. The problem is that the multi-parametric MRIs that we have existing in Jamaica at this point in time, this one located at the Leet and the other at Winchester, they're down. You know, but you can get information, because these higher Tesla MRI give you information about the actual prostate itself, and they classify the lesions that they see in terms of a PIRAD score, right? So if you have a PIRAD 4 or 5 lesion in the prostate, then you better go and get a biopsy. But just to mention that, and I want to emphasize that below a PSA of 4, right, 15% of cancers are still diagnosed. In fact, I have a gentleman right now, his PSA never rose above 2, right? And because his rectal examination was abnormal, he did a biopsy and it was shown to be cancer, right? So the digital rectal examination will not cause you to become a homosexual, right? And I had to do one. All of us men probably have had to do one, and we are men. It does not change how we view our partners. So I would encourage, if he's that averse to doing the rectal examination, to step up, do an ultrasound or MRI. MRI better, because that will tell you for sure whether you have a lesion that is worth doing a biopsy on.
Okay. All right, just to continue on that trend, I must say that this whole thing with that is a stigma out there, the stigma is real. And it is something that we need to even address from a government standpoint. If you notice, our advertisements are centered around pap smears and breast cancer. If you notice, we talk about the prostate cancer focus awareness, and this is fairly new, but all the time that emphasis with the pink ribbon and that kind of thing is focused a lot more on our women and female in our society. So we really have to build get a communication strategy going. We need to educate our men about the importance of doing the test. We have to bring a whole change the approach in terms of making it, sharing the comfortable aspect of it, the realness of it, and so on. Because honestly, most of our men see this test as a stigma, and they have all kind of misinformation out there, and we need to do something in correcting that. Most of the persons that I interact with on a regular basis, and especially men, when we have conversations like those, they push back at the test. And that is, I'm just sharing my experience with interacting with young men. And as a matter of fact, it's not even cultural, because most of who I interact with are men overseas, and they experience the same stigma, even though we say that in the Caribbean it is more prevalent than it is in other countries, and it is mostly in our Black men than in Caucasian, that kind of thing. But even then, even though it's not so prevalent, they still have the stigma in their heads. So I think it's men in general, and I think we can create something, some communication around it that can make it not so fearful for men when we talk about this kind of thing. So what we need to do from our end is keep knocking on the doors of those who who deal with this have to deal with this kind of things, or physicians, whoever have to deal with that kind of thing, and so on. We keep knocking on the door that our governments, our churches, we put this in the forefront, so that we can preserve our men, so that they can, be good examples and good fathers and that kind of thing in our society, than running around being fearful of getting tested for prostate cancer.
All right, so we're out of time now. So I'll give the members of the panel an opportunity to just give the closing remark, and then I'll hand over to Pastor Adrian Johnson, so that he can close off Men's Ministry Director. So I'll allow you to give your closing remarks, and then I'll say thank you. Then I'll hand over. I'm not sure who wants to go first.
In terms of the stigma towards digital rectal examination, it does exist. It's perhaps maybe 40% of the people who come to the doctor and you offer to do that test as part of their examination. Maybe 40% will have a pushback. But in order to solve that problem, we need to ask other questions, perhaps not directly related to the prostate. I believe that there is something happening, or might have happened in the life of some of these persons that lead them to this fear. And for us to get over this is not just to beat on the door, but if we could get behind what is getting on in their minds, and perhaps that's where Brother Anderson would come in, and people who practice in his area, that we need to find out what is it that is going on in their minds, or what experience they might have had that influenced them to do it. Because I must say that I have had that digital rectal examination. It is just a discomfort as any other discomfort, no more discomfort than if somebody was looking in your ears or some other part of you. So it is not significant. However, some people have a deadly fear of that, and there is something else happening in the minds of these people that is stimulating this fear. That some studies should be done, not necessarily in relation to the prostate, and to see what is causing this great fear. Another thing, though, is that the fear is transmitted to others, because just as much as we get this pushback from doing the digital rectal, there are many women who do not want to do a mammogram because simply that they hear that it is hot, and somebody would have had an experience and transmitted that to somebody else and to somebody else, and so you have people resisting doing mammogram because they hear that it is hot or it is uncomfortable, and the members of the females close to me tell they go and do their mammogram without any adverse effect or without any argument. So we just need to have those people who find that it is the reality of it, and that it is pretty much harmless, to transmit that to the other men around them. Thank you.
All right. I would close by saying this. I want to close on a text. It said Jeremiah 29 and verse 11. And it says, "For I know the plans I have for you, declares the Lord, plans to prosper you and not to harm you, plans to give you hope and a future." So a reassurance that God's plan for you are full of hope, even when circumstances seem bleak. I think that based on what the brother shared with us in his testimony, in terms of his faith factor, I think, yeah, sometimes we tend to want to separate the two things, but I think our faith factor has a lot to do with our mindset and how we approach the different problems that we face, even from a health perspective. So that is how I would end it. You know, have God involved in our decision-making process. Have him, you know, he will whisper into our ears what we need to do, and we should not have the fear of getting tested. You know, but the fear is real. But then I think that things can be done for us to mitigate against that, so that more of us can go get tested and we can get healthy. That's it.
Pastor Steele?
Yes, we need to understand that having an enlarged prostate doesn't necessarily mean that you will die. And this is the message we must send to our men, that it is a part of nature, it's a part of life. And God did not give us the knowledge and the wisdom to believe that we live forever. But he does say that if we follow his precepts, his principles, the laws of health, and so forth, that we will add a little extra time to our lives. And therefore, we need to continue to encourage our men. As Ellen White says, educate, educate, educate. That is the only way out of this thing, because as you mentioned, that there's a cultural effect that is impacting on our men, the homophobia and so forth. And therefore, the only way out of this thing is education. So let us as a people, as a church, continue to educate our men in our church. Men ministry must really take up this challenge and make sure that this be a part of their educational tool as we go forward. Then we will be able to help others outside to understand that God is able to deliver us. Thank you.
Thank you. Dr. Greaves, I'll give you the opportunity to speak, and then I'll just do my closing remarks and hand over to Pastor Johnson. You're muted. You're muted, Dr. Greaves. Still muted.
Okay, I was getting a message that I was muted by the host. Sorry. Let me say that some Seventh-day Adventist men will still come down and be diagnosed with prostate cancer. It is not a death sentence. I think we owe it to ourselves to find out as much about the disease as possible. We need to find someone close who we can discuss it with. And in this vein, in our churches, I think a lot of people hide that their diagnosis. There's need for a prostate cancer support group in the men's ministry itself, and where people can exchange ideas on how they cope and the kind of people they had to go to. Now, the problem with coping is a problem. Psychologically, I've had to refer certain people to Dr. Barry Davidson at Family Life Ministries for counseling and whatnot. But it's a disease that, if treated, you can get over. And repassion your life and continue with your life as it was.
All right, thank you very much, gentlemen. And for those of you who are, well, our viewers, whether you're on Zoom or on YouTube, thanks for your question. Thank you for joining us at the Prostate Cancer Awareness Forum. So we hope that this discussion has highlighted the importance of prostate health for you, as well as the resources available for our men and the families that surround us men here in Jamaica and no doubt throughout the region. So we just want to remind you that early detection is vital. You heard that from everyone here, as well as from the gentleman who gave the testimony as well. So consult your healthcare provider about regular screenings, and let's continue to raise awareness and support each other in this cause. I am Kwame Thomas, your moderator. Over to you, Pastor Johnson.
Thank you so much, my brother and friend. Certainly, this evening has been a wonderful evening, even inspiration and information. We're really grateful for what we have learned and what we have heard. We have had approximately 70 persons on YouTube and approximately 100 persons on Zoom here. Of course, we're really happy. I just want to say thanks to Dr. French, Dr. Steele, Dr. Reeves, of course, also Brother Anderson, and also Brother Gordon. I also want to say thanks to the communication team from the conference, my assistant, Sister Naisha Brown. Also, I want to say thanks to my wife. My wife has been such a strong source of help to me as it relates to the ministry. I want to say thanks to Dr. Steele too. Team effort, and this is something that we really want to have yearly. And I like what Dr. Reeves said a while ago, that we need to establish what we call the prostate cancer support. And this is something that we want to see within the church. And of course, some things coming out of this discussion this evening, I think all of us as men to take note of early detection, as Brother Kwame has just said a while ago, dieting, whole matter of trusting God, family and friend support, as we certainly look at our men's health. Thank you again. And I want to thank my president. He has been a source of help to all of us as it relates to the whole matter of our session here. Certainly. How can I forget the host? Sorry, not the host, the moderator, Ella Kwame. Thank you so much, Ella Kwame, for the support. Again, let us.
My pleasure.
The Bible says, I wish above all things and be in health. So again, bye from Men's Ministry and Health Ministry, Prostate Cancer Awareness Forum. Until next year, God spare our lives. Have this. Thank you again, everybody.
And Pastor Johnson, thanks to you for your leadership. And this is highlighting one of our strategic initiatives.
Certainly.